In other solid tumors, VEGF has been shown to be a viable target for anti-VEGF therapies, and bevacizumab showed positive results in a number of solid tumors, including colon cancer. So in esophagogastric cancer, bevacizumab was studied combined with first-line chemotherapy on the AVAGAST trial, and although it did show improvements in response and progression-free survival, ultimately it did not translate into a survival benefit. So right now we're not using VEGF therapy first-line. Ramucirumab, which targets the receptor, it's a receptor-blocking antibody that blocks the VEGFR2 receptor, was shown in a phase 1 trial to have some activity in metastatic gastric cancer, and that led to 2 randomized trials of this drug. One looked at patients progressing on first-line chemotherapy and randomized patients to supportive care versus ramucirumab monotherapy. That was a positive trial showing that ramucirumab improved progression-free and overall survival compared to supportive care, demonstrating that the drug had single-agent activity. It didn't induce responses, but it did stabilize the cancer. The more clinically relevant trial was in patients failing fluorinated pyrimidine platinum upfront chemotherapy when they were randomized to standard second-line weekly paclitaxel with or without the addition of ramucirumab. Paclitaxel and ramucirumab was the superior arm. All the endpoints were improved. Progression-free survival was improved by a little bit less than 2 months. Overall survival was improved by 2 months, and the response rate was increased by 12 to 15%. So based on that very positive trial, after patients progress on first-line FOLFOX or fluorinated pyrimidine platinum-based chemotherapy, the standard of care is for patients to get paclitaxel ramucirumab. That being said, there was a lot of interest then in studying ramucirumab in first-line chemotherapy, and the results from that trial were recently presented at the GI symposium earlier this year, and unfortunately it was a negative trial. They did show an improvement in progression-free survival with the addition of ramucirumab to first-line 5-FU platinum-based chemotherapy, but it didn't translate into a survival benefit, and there was no improvement in response rate. So based on that negative trial, ramucirumab will not likely be pursued in first-line treatment. So we don't clearly have a first-line VEGF-targeted drug. These drugs should be used second-line in combination with paclitaxel.
Ramucirumab, which is another interesting targeted drug targeting VEGFR antibody, has made its way in gastric cancer. So patients have been studied in 2 clinical trials, the REGARD and the RAINBOW clinical trial, both in the second-line setting. These patients were seen to have an improvement in median overall survival when it was used, ramucirumab was used as a single agent versus when it was used with paclitaxel in both these trials. So we clearly see that there's been an improvement with median overall survival, yes, by just a few months, but clearly made a significant improvement in the disease that is gastric cancer by the combination use of ramucirumab with paclitaxel. So there was a recent trial published called the RAINFALL trial, which used ramucirumab in the first-line setting, and unfortunately that was a negative trial. So for now, ramucirumab stands as a good option for second-line with or without paclitaxel combination.
Although ramucirumab as monotherapy has disease stabilization, it's inferior to ramucirumab plus chemotherapy. Virtually none of us are going to give ramucirumab monotherapy second-line. It induces no responses. The benefits are marginal, and we're pretty much going to give chemotherapy second line, and the ramucirumab paclitaxel data argue that should be the standard. NCCN guidelines actually list ramucirumab as a less optimal treatment alone because it really offers no responses in patients and briefly stabilizes the cancer.